Good day, everyone. My name is Kehinde Oshinowo, Director of Programs Association for Reproductive and Family Health. The title of my presentation today is DMPA-SC and self-injection as an evidence-based service delivery approach to improve family planning uptake in the light of COVID-19. The study sites are 10 Rasudin project states: Anambra, Delta, Enugu, Kwara, Lagos, Niger, Ogun, Oyo, Plateau, and Rivers. As a background to the study, we are all aware of the uproar surrounding COVID-19. The pandemic has imposed an unprecedented restriction which kept countless clients from visiting healthcare facilities for essential health services, including family planning. COVID-19 pandemic and the associated measures put in place to mitigate its spread further constrained routine access to treatment. It is estimated that if not well managed, COVID-19 will have huge impact, negative impact for that matter, on the FP gains previously recorded. Health system and service providers have an urgent opportunity to promote self-care and access to family planning. DMPA-SC and self-injection are gaining traction in Nigeria as a convenient, effective method to address significant unmet need for family planning. Rasudin project in 10 states employ demand and supply approach through facilities and door-to-door service delivery by trained corps and community volunteers at the communities and hard-to-reach area as an evidence-based measure to reduce challenging work environment during COVID-19 peak. The study goal for that I'm presenting is to explore the feasibility of DMPA-SC and self-injection as an intervention for sustaining family planning services and self-care during the COVID-19 pandemic. We were interested in research questions that would take us to in-depth evidence that will show the level of uptake of DMPA-SC as family planning method makes in the 10 Rasudin project states. So we wanted to know what is the level of uptake of DMPA-SC. We wanted to know what was the level of acceptability of DMPA-SC self-injection during COVID period. We wanted to know if DMPA-SC and self-injection have the potential to be the game changer among family planning method mix. Our objectives were tailored towards the research questions, and we wanted to explore evidence-based channels of intervention for sustaining DMPA-SC and self-injection and other family planning methods and self-care in the light of COVID-19 pandemic. We wanted to determine the most appropriate service delivery approach for family planning uptake during COVID or any force majeure. We wanted also to determine the most feasible method in FP uptake during the peak of COVID lockdown. Our methods and materials were basically from data from the facility through the NHMIS on DMPA-SC uptake from 10 states. Our study was focused on the data from 6,340 public health facilities and 870 community resource people who were retrospectively analyzed and compared. Data were classified as pre-COVID-19 between December 2019 to February 2020, the peak of COVID and the lockdown period between March to May 2020, and post-COVID-19 period, June to 2020. Our results, especially exploring the channel and level of uptake of DMPA-SC, revealed that pre-COVID, we assessed data from 6,340 service delivery points and 870 corps, as earlier mentioned, from 10 project states. During this phase, 81%, that is 33,693 of the 41,611 clients with DMPA-SC and self-injection uptake were from facility service provider, and only 19%, 7,918 were from corps, with a total of 751 self-injection cases were recorded. During the peak of COVID, proportionally, uptake increased by 41.9% and 117% from the facility providers and corps respectively, showing that most of the services were provided at the community level. Specifically, self-injection recorded an astronomical increase of 76% from the pre-COVID period, with 751 clients, to the COVID peak with 1,326, comprising of 387 from the facility, and the corps provided 939 self-injection. This is not surprising given the fact that the corps were committed to comprehensive counseling services to their clients, as well as willing to train clients on how to self-inject when compared to what obtains at the facility level. Post-COVID, the total DMPA-SC uptake continued to increase after the peak of COVID by 42%. Of this number, 2,843 SI clients were recorded, and the facility providers contributed 38.8%, making 64,020 clients, while the corps contributed 67.3%, 28,765 increase. We like to note that generally the absolute numbers of facility contribution to total DMPA-SC uptake was higher than that of corps. The contribution of corps to self-injection was higher than that of facility service providers. Self-injection continued to show a progressive increase in uptake through the services of both facility service providers and corps in the pre-COVID-19, peak COVID-19, and the post-COVID period. The contribution of corps was higher in initiating self-injection when compared with the trained facility service providers, especially during the peak of COVID, by 117% when compared with 41.8% results at the facility level. This graphical presentation, if you look at the green color, which represent the new acceptors, just before the peak of COVID, we recorded 8,652 new acceptors, while we recorded 6,694 revisits and 431, which is the blue bubble, as self-injection. Surprisingly, during the peak of COVID, there was a sharp increase from the preceding month to 11,441 new acceptors. In April, we had 11,970, and by May 2020, we also recorded 12,431 cases of DMPA-SC. We can see that the trend was sustained all through the peak of COVID. And this is because our community workers were working in the various communities and also providing services when some of the facilities were not opened. We also like to note that post-COVID, we were still able to maintain that traction as depicted in this graphical presentation. And by the end of the post-COVID that we measured, we already had over 22,000 cases. Now, this slide is to show the contribution of COPs and facility to SI utilization. The yellow color is the SI facility level implementation, and the red color is the self-injection through the COPs. All through the period of COVID, there was significant increase in the uptake through the use of COPs when compared to the facility level of intervention. But you will see that as soon as the lockdown was lifted, the SI at the facility level increased to 500 when compared with that provided by the COPs. But we know that we are looking at the total number of facilities that were reviewed, and 6,340 when compared to 870. So proportionally, the COPs were really providing optimal self contribution to uptake of DMPA-SC throughout the COVID period, peak of COVID and post-COVID as well. What is the level of DMPA-SC when compared to other family planning methods? And can it be a game changer? And yes, of course, because during the peak of COVID, 72% of all family planning utilization were contributed by DMPA-SC self-injection method when compared to other methods. We could see that DMPA-SC utilization during the peak of COVID was 19,000 in March from the total 31,249. So when you look at the average at this period compared to other methods, DMPA-SC contributed to 72% of family planning uptake. We can see that post-COVID, post-peak of COVID, the narrative was changing, and that other family planning methods also picked up. That is not to say that if you really compare other methods, the number of other methods and the uptake of from the facility, from the community, we will see that comparatively the performance was good. I want to safely conclude that based on the findings from our results, that community level service delivery of DMPA-SC through the COPs was successful in the sustenance of service traction and the gains of family planning service delivery during COVID. Self-injection will reduce missed opportunities during the peak of COVID period and increase self-care. That there was 70.8 increase in self-injection administered by COPs between the pre-COVID and the peak of COVID. This suggests that direct-to-client access at the community level holds greater promise than facility channels in closing the access gap and averting thousands of unplanned pregnancy that could have happened at that time and addressing unmet need for family planning. So we want to look at the programmatic implication of our study and the recommendation to the government of Nigeria. We want to recommend to the government of Nigeria that we should explore replicating this model across the 36+1 states, as it has proven to be the game changer for family planning uptake. We also know that exploring mechanisms for expanding community-based service delivery for other method mix like implant oral pills, relatively safe for administration by trained chws at the community level, should be optimized. We were told that Maristopes is currently pilot testing the administration of the implant at the community level. Our appreciation to the donors of this grant, Bill and Melinda Gates Foundation and Children Investment Foundation Funds, Federal Ministry of Health for the efficient coordination and leadership, National Primary Healthcare Development Agency, State Ministry of Health and State Primary Healthcare Board, and community stakeholders for the enabling and supportive working environment. For facility providers, corps, and CVs for their selfless commitment as the frontline workers during the COVID period. For our partners, Center for Communication and Strategic Information, in their partnership in the demand generation and the visibility in the state, working with the health promotion unit to create awareness about the family planning methods. And for all our family planning and LGA coordinators from the 10 project states, we want to say thank you to you. Thank you for the success of this project, because without you, we wouldn't have been able to record this success. Thank you.